Hello dear students, I welcome you all to this series of lectures on internal medicine. This is Dr. Maitreyi and we'll be starting off with our lectures on cardiology. So whenever it comes to cardiology, we should be very thorough with the basics. So we'll start off with the arterial pulse, the JVP, heart sounds and murmurs, and then move on to ECGs and core cardiology. Right? So let us start off with the arterial pulse. So what is the arterial pulse? The arterial pulse is basically the pressure wave which is generated during the systole and it is transmitted to the peripheral arteries. So as we all know, the systole is basically when the heart contracts. So when the heart contracts and the blood flows into the aorta, the blood is then carried to the peripheral arteries, which causes expansion of these peripheral arteries, right? So this is what we feel as the peripheral pulse. So let us understand the basic physiology behind which how the normal pulse wave is generated. So first let us look at when the heart is contracting, there is blood in the LV and the blood is then pushed out to the aorta. So this results in a positive pressure in the aorta. So this is basically what is demonstrated as the first upstroke in the pulse waveform. So this first upstroke in the pulse waveform is what we call as this first upstroke in the pulse waveform is what we call as the percussion wave. Okay. So the percussion wave is the first positive pressure waveform which is generated when the blood flows from the LV to the aorta. Now let us look at the aorta. Let us say that this is the aorta and there is blood. So we know that the aorta is elastic vessel. So when the blood fills in the aorta, don't you feel that there will be some amount of recoil, right? So there will be some amount of recoil in the aorta and there will also be some amount of resistance as the blood flows into the peripheries. So there will be some amount of resistance which as the blood flows to the peripheries and this results in a further positive wave. So the second positive wave which is generated is what we call as the tidal wave. So what is the tidal wave? So the tidal wave is basically the second positive wave which is generated because of the elastic recoil of the aorta and the resistance provided by the peripheral arteries. So we have understood these two pressure waves, the percussion wave and the tidal wave. Now once the blood moves into the peripheral arteries, what has happened? The heart goes into the relaxation phase of the diastole, right? So the pressure begins to drop slightly and this is followed by the closure of the aortic valves. Yes, the aortic valves close and this is what is demonstrated by a notch which is called as the dicrotic notch. Okay. So let us just imagine this tube. There is fluid which is flowing in through this. Right? So when we suddenly stop the flow by the closure of the valve, what happens to the pressure? The pressure slightly increases, right? So this is what results in this small notch which occurs during the closure of the aortic valve, which is called as the dicrotic notch. Followed by the dicrotic notch, the pressure will continue to fall as the heart relaxes during diastole. And this is what we call as the dicrotic wave. Alright, so we have understood the different waves of the pulse. So it comprises of the percussion wave, it comprises of the tidal wave, it comprises of the dicrotic notch and the dicrotic wave. So can we derive that the entire portion from here to here is what we call as the anacrotic limb, which is up to the entire systole. This is what we call as the anacrotic limb. And following the closure of the aortic valve, we have the dicrotic limb. And this is what is the systole and this is what is the diastole. So can we also say that the peak pressure that is generated during systole is what is nothing but the systolic blood pressure. So this gives us the systolic blood pressure. Okay. So this is about the normal pulse and the normal pulse waveforms for you. So whenever we check for the pulse, what are the different aspects that we look at? So what are the different aspects that we look at when we check for the pulse? We look at the rate, we look at the rhythm, we look at the volume, character, condition of the vessel wall, and we also look for any radioradial or radiofemoral delays, right? So what is the normal rate? The rate varies from 60 to 100 beats per minute. So this is what is considered to be within the normal range. So you remember R for R, where is the rate and rhythm best appreciated? It is best appreciated in the radial pulse. Okay, so the rate and rhythm is best appreciated in the radial pulse. So what is tachycardia? So tachycardia basically refers to a heart rate of more than, rather a pulse rate of more than 100 beats per minute. What is bradycardia? Bradycardia is nothing but the pulse rate of less than 60 beats per minute. Okay, so we've understood what is a normal rate, right? Then we also look at the rhythm. So rhythm basically means that when you palpate for the pulse, you see whether each pulse is occurring at a definitive equal interval. So that is what we look at, which is nothing but the regularity of the pulse. So this can be classified as regular as well as irregular pulse. So whenever each P wave is followed by a QRS complex on the ECG, we will be looking at the ECG waves a little later on, but this is some basic knowledge that we all have. So whenever the SA node contracts and there is generation of the P wave with the atrial contraction followed by the ventricular contraction, right? So this is what we mean by each P wave is followed by a QRS complex, then this is a regular rhythm or what we call as a sinus rhythm. Right? So sinus rhythms are regular rhythm. Then what is an irregular pulse? An irregular pulse can be classified as regularly irregular. That is when you check it for a whole minute, the pulse is occurring irregularly, right? So it occurs irregularly, but the intervals at which it is occurring irregularly is regular. So this is what we call as a regularly irregular pulse, or an irregularly irregular pulse. So this is a regularly irregular and an irregularly irregular pulse. So where do you get an irregularly irregular? It's a completely chaotic activity. That means what? The SA node generates the impulse, the atria are not contracting in relation to the ventricle, and there is a complete chaos, and this is what we see in atrial fibrillation. Right? So where do you see a regularly irregular pulse? This can be seen in atrial flutter with a definitive block. So the blocks are coming at a specific interval, however there is chaotic atrial activity and ultimately it gets conducted to the ventricles and it is felt as a pulse in a regularly irregular fashion. So that is about the rate and the rhythm for you. Now let us look at a very interesting point, what is called as the Paget sign. So as we all know, during fever, what do you expect the pulse rate to be? The pulse rate will be higher, right? So for every 1 degree Fahrenheit rise in the temperature, the pulse rate is expected to increase by at least 10 beats per minute. But in certain conditions, what happens is that the pulse rate does not raise according to the expectations, right? So this is what we call as the relative bradycardia. So this is what we call as the relative bradycardia. So what is relative bradycardia? There is fever, there is anxiety, but so what is relative bradycardia? So there is fever, there is an increase in temperature. So for every 1 degree rise in temperature, you would have expected the pulse rate to rise. So you will expect tachycardia, however that is not there, and this is what we call as the relative bradycardia or the Paget sign. So where do you see this Paget sign? Paget sign is seen in some infections. The infections that you have to remember very importantly is the typhoid fever. Then you have to remember dengue, you'll have to remember brucella, right? And in certain forms of drug fevers, in certain form of drug fever, and factitious fever, you can find relative bradycardia. Okay, so this is what is the concept of relative bradycardia or Paget's sign. So I hope we have understood what is the rate and what is the rhythm and what is Paget's sign. Now let us move on to the character. The next aspect of pulse that you should be knowing is the character. So can you see here that as we move from the carotid to the femoral pulses, right? So when you move from the carotid artery to the brachial artery to the radial and then the femoral artery, can you see that the height of the pulse wave is increasing? So this is physiologically seen because as we move from the center to the periphery, the resistance of the peripheral vessels is much higher. So as the resistance of the vessels is higher, the peak of the pulse wave is also higher, right? So this is a normal phenomenon that is seen. So don't you think that the character of a pulse will be best appreciated in the carotid artery? Right? So this is an easier way to remember it. It is C for C. So the character of the pulse is best appreciated in the carotid artery. We will be looking at the various other characters as we move on. Okay. So now we go on to the next aspect, which is nothing but the condition of the vessel wall. So how do you look for condition of the vessel wall? Whenever you palpate the pulse, you look for the thickening of the arteries. You look for thickening of the vessels. Why? Because as we age, there can be some amount of thickening of the arteries. Apart from that, in individuals with atherosclerosis, there can be thickening of the vessels, and that is the reason why we have to look for the condition of the vessel wall. The next aspect that we look for is for delays. What do you mean by delays? You look for a radial delay or a radiofemoral delay. So what does that mean? So when you palpate both the radial arteries together, you would expect that the pulse arrives at the same time. However, if there is a delay where the one side of the radial artery you feel the pulse, the other side occurs at a later interval. Or similarly comparing the radial artery to the femoral artery. So this is what we call as the radioradial or radiofemoral delays. So where is this found? This can be found in coarctation of aorta. Right? So this can be found in coarctation of aorta. Okay? Fine. So what all have we learned here? I will just show it to you. So we have looked at the definition, we have looked at how the normal pulse wave is generated and what are all the waveforms and the reasons for the various waveforms. We have looked at the rate, rhythm, Paget's sign. We have looked at how and where do we assess for the character of the pulse, how do you look for condition of the vessel wall and the various delays. Now let us look at the character more in detail and we look at the different types of pulse waves. So the first pulse wave that you should be knowing is the hyperkinetic pulse. So can you see from here what is the waveform that is here? So if we draw the normal pulse wave for you, if we draw the normal pulse wave, it's something like this. So what has happened here? The volume is increased. So a pulse wave in which the volume is increased is what we call as the hyperkinetic pulse. So which are the conditions where you can have a hyperkinetic pulse? It can be seen in physiologic conditions. Physiologic conditions when there is anxiety. Right? When there is anxiety, don't you feel that your heart is racing or your heart is pounding? That is because there is an increase in the rate as well as an increase in the volume of the pulse. So you can have a hyperkinetic pulse. You can have it during fever, as we had discussed when we were discussing relative bradycardia, that with every 1 degree rise in the temperature, the pulse rate will increase, right? So you can have a hyperkinetic pulse with fever as well. During exercise, don't you feel that the heart has to pump out more blood to cater to the needs of the exercise? So during exercise, you can have a hyperkinetic pulse. Apart from this, hyperkinetic pulse is seen in pathological conditions. So the pathological conditions where the hyperkinetic pulse is seen is in volume overload states. Wherever there is a volume overload state, you can see that there is a hyperkinetic pulse, or in conditions where the cardiac output is increased, where the cardiac output is increased. So this can be seen in conditions like a ventricular septal defect. It can be seen in conditions like the ventricular septal defect, or it can also be seen in conditions like beriberi, where there is a high output cardiac failure. You can see a hyperkinetic pulse. So that is about the hyperkinetic pulse. Let us look at the second waveform and draw the normal pulse for you. So suppose this is a normal pulse. Can you see that this pulse is of lower volume? So this is what we call as the hypokinetic pulse. Where do you think you find the hypokinetic pulse? In conditions where the cardiac output is decreased. So this is seen in heart failure. Okay. Now let us move on to the next waveform. What is seen here? You are seeing a slow rise and a late peak, right? So this slow rise and late peak, this is what is also called as the Pulsus Parvus et Tardus, which is the slow rising and a late peaking pulse. So where do you see the slow rising and late peaking pulse? You see it in severe aortic stenosis. What is aortic stenosis? When the aortic valve is stenosed, or when it is thickened and the area of the aortic valve is reduced, the blood cannot easily flow from the LV to the aorta. So this is what we call as the aortic stenosis. And what is the pulse waveform that is seen here? It is the slow rising and the late peaking pulse, which is the Pulsus Parvus et Tardus. Okay. So we have seen your hyperkinetic, hypokinetic and the Parvus et Tardus. Now let us look at this pulse wave. So this is a very important conceptual pulse wave that you should know. So what can you see here? You can see two peaks, yes, followed by the dicrotic notch. So you can say that there are two peaks in where? There are two peaks in systole. So this two peaks of the pulse wave in systole is what we call as the pulsus bisferiens. Okay. So let us look at the mechanism of pulsus bisferiens and you will understand why certain conditions have this pulsus bisferiens. Okay. Fine. So let us see where all it is seen first. So this is seen in AS with AR, aortic stenosis with aortic regurgitation. It can also be seen in hypertrophic obstructive cardiomyopathy or HOCM. It can also be seen in severe aortic regurgitation. Okay. So AS with AR, HOCM and severe aortic regurgitation is where you see this pulsus bisferiens. So let us understand the mechanism of pulsus bisferiens with this diagram. Okay. So before that, let us understand this basic physics principle. So whenever the blood or whenever the fluid is flowing through a narrowing, as you can see here that the fluid is flowing through a narrowing or a narrowed opening. So what happens is that the velocity with which the fluid flows increases as it narrows, right? So if it is flowing through a tube and there is a sudden narrowing in the tube, the velocity of the flow increases and the area surrounding it, there will be a decrease in the pressure. And this effect is what we call as the Venturi effect. So when there is a fluid which flows through the tube and there is a sudden narrowing that it encounters, when there is a fluid that flows through the tube and there is a sudden narrowing that it encounters, what happens to the velocity? The velocity increases and in the area surrounding the tube, the pressure drops. So this is what we call as the Venturi effect. Okay, so this Venturi effect is what comes into play in our understanding of the pulsus bisferiens. So let us look at this. We'll look at the heart and apply the same aspect to it. So let us look at this condition where there is an aortic stenosis with aortic regurgitation. So we'll look at the condition where there is an aortic stenosis with aortic regurgitation. So there is blood here. This is your LV, this is your LA and this is your aorta. The blood is flowing through a stenosed valve. As the blood flows through the stenosed valve, it has to encounter a higher pressure gradient, right? So this results in your first peak as it moves through this stenosed valve. Now after it moves through the stenosed valve, as there is some amount of aortic regurgitation, means what? There is some amount of flow that is coming backwards as well. Right? So this extra flow that is coming backwards as well, as we all know from the Frank-Starling law, what happens when the volume increases? The stroke volume will also increase if the end diastolic volume increases. So the contraction also increases, right? So because now there is more amount of blood in the LV tried to completely push out the blood. However, there was regurgitation. That means that there was some amount of backflow and the blood has flown back into the LV. Now there is more blood that the LV has to push out. So this results in your second peak. So this is how you get your pulsus Bisferiens in AS with AR. Okay, now let us apply this Venturi effect to this another condition, which is your hypertrophic obstructive cardiomyopathy. In hypertrophic obstructive cardiomyopathy, where is the obstruction? The obstruction is at the subaortic level. The obstruction is at the subaortic level. So in this subaortic level, what happens? We apply the same principle. Because there is an obstruction here, the blood flow that happens, the velocity increases. The velocity increases as it encounters the narrowing. What happens to the pressure in this area? Let me use another color. What happens to the pressure in this area? The pressure decreases, right? The pressure decreases. Now, because of this decrease in pressure, what valve is nearby? What valve is nearby here? This is nothing but your mitral valve. This is nothing but your mitral valve. This mitral valve gets sucked in because of the low pressure. It gets sucked in and it blocks the aorta temporarily. And this is what we call as the systolic anterior motion of the mitral valve, or the SAM. A very famous word which is used in HOCM is your SAM. So let me just explain this to you again. Initially during systole, the heart contracts and the blood flows into the aorta. Now because of the narrowing, let us say that this is the LV and this is the aorta. Now because of the narrowing, what happens to the velocity? The velocity increases. What happens to the pressure in the surrounding area as it decreases? Right? Now the mitral valve is here, it's opening like this. Now moment there is a sudden decrease in the pressure, the mitral valve gets sucked in and it causes an obstruction at the level of the aorta, and this is what we call as the SAM, or the dynamic obstruction, which is seen in HOCM. Correct? So why should we understand this concept is one thing is that we are applying the Venturi effect, and this is how the SAM happens. SAM happens because of Venturi effect. Second is because the initial peak is because of the obstruction. The second peak is because of the SAM. Right? So the second peak is because the mitral valve comes, gets sucked in and it obstructs the aorta, and this results in a increased pressure and a second peak in the pulse, and this is what we call as the pulsus Bisferiens. The type of pulse which is seen in HOCM also has an other name which is called as the spike and dome pattern. This is also called as the spike and dome pattern. Okay. So I hope you have understood pulsus Bisferiens completely. You have understood the concept of Venturi effect and how this causes the pulsus Bisferiens in HOCM, in AS with AR, and in severe aortic regurgitation as well. Now let us move on to the next pulse character. So what is this wave? You are seeing there is a normal waveform, but you are seeing that the dicrotic wave is more exaggerated. So this is what we call as the dicrotic pulse. So an exaggerated dicrotic wave is what we call as the dicrotic pulse. And this can be seen in some forms of heart failure. Okay. Now let us look at this pulse waveform. So can you see here that the pulse is varying during inspiration and expiration? There is a change in the volume of the pulse, right? So there is a change in the volume of the pulse during expiration and inspiration. What are you seeing? That there is a drop. There is a drop in this pulse variation during inspiration and expiration. Or in other words, you can also say that there is an exaggerated fall in the blood pressure, exaggerated fall in the blood pressure. Right? So during inspiration, what happens? Let us understand this mechanism. During inspiration, there is a negative intrathoracic pressure and the venous return to the heart increases. Venous return to the right side of the heart increases. If the venous return to the right side of the heart increases, the blood is then pushed into the pulmonary arteries. But the pulmonary arteries are generally more capable of dilatation and they retain the blood for a longer time. So what happens to the blood flow to the left side of the heart? Blood flow to the left side of the heart decreases and hence the blood pressure also decreases. Correct? We will explain this once more as we move forward, but this is a normal physiological phenomenon. So during inspiration, there can be a fall of the systolic blood pressure. However, if there is an exaggerated fall in the blood pressure more than 10 millimeters of mercury, so an exaggerated fall in the blood pressure during inspiration to more than 10 millimeters of mercury, this is what we call as the Pulsus paradoxus. So this is what we call as the Pulsus paradoxus. So what is the paradox here? Why is it called as the Pulsus paradoxus? So in those days when the Pulsus paradoxus was identified, the paradox was that the heart sounds were heard, however the pulse was not felt. That is because there is an exaggerated fall in the blood pressure during inspiration. So don't you feel that the pulse will not be felt at all, but the heart sounds were heard. If the pulse was not felt, in those days they would obviously think that the patient is no more. So that is the reason why this was named as Pulsus paradoxus. The paradox here is that the heart sounds were heard, but the pulse was not felt. Okay. So let us understand this concept better with the help of the diagram. Right. So during inspiration, what happens is that there is increased flow to the right side of the heart. The blood flows here. As the blood flows here through the RA, through the RV, it goes to the pulmonary arteries. But the pulmonary arteries have a lot of capacitance, they are more elastic and it causes pooling of the blood in the pulmonary arteries and the pulmonary vasculature. So if there is pooling of the blood, what happens? The flow to the left side is decreased, right? So there is no flow that happens to the left side of the heart. So there is a decreased flow to the LA, LV and there is a decrease in there is a fall in the blood pressure. Okay. So when this fall is more than 10 millimeters of mercury, this is what we call as a Pulsus paradoxus. But you would be asking me, this is a BP finding, right? Then why is it called as a Pulsus paradoxus? Why is it a pulse finding? So that is what is seen in this diagram. The pulse volume will be varying and it is more so evident during inspiration and expiration. That's why it is also a pulse finding. But how would you effectively demonstrate it? If you have to demonstrate it, you have to demonstrate it using a sphygmomanometer, right? You have to demonstrate it as a BP finding. Okay. So what are the conditions in which Pulsus paradoxus is seen? Now let us see that with the help of this diagram. So where is it seen? It is seen in a condition called cardiac tamponade. So what is cardiac tamponade? So cardiac tamponade is basically a condition where, as we all know, the heart is surrounded by what? It is surrounded by the pericardium, right? And the pericardial fluid is very minimal. It is usually only about 15 to 30 ml. But in certain conditions where there is a trauma, if there is a hemopericardium, or in certain conditions because of inflammation, there can be accumulation of fluid in the pericardium and this results in compression of the heart, right? So much fluid in the pericardium resulting in compression of the heart, this is what we call as the tamponade. So cardiac tamponade is a very important condition where this Pulsus paradoxus is seen. So what happens in this? During inspiration, as I said, the blood flows to the right side of the heart, RA, RV, right? Now, the RV is dependent on the LV. In these kind of conditions, there is a situation which arises which is called as interventricular dependence. What is the reason for this? So when there is the tamponade, the heart is expanding against the pericardium. However, the pericardium does not allow the RV to expand because it is having a lot of fluid and it puts pressure back into the heart. So the RV cannot expand and because the RV cannot expand further during inspiration as the blood flow into the RV increases, it expands into the LV, right? So the septum moves into the LV. It cannot expand further into the pericardium because of the pressure which is there in the pericardial fluid. So this expands into the LV. So as the septum moves further into the LV, don't you feel that the cardiac output which is from the LV is compromised? So the cardiac output from the LV is reduced, and this results in the Pulsus paradoxus. Right? So this results in the Pulsus paradox. Okay? So where are the other conditions where you can find Pulsus paradoxus? Pulsus paradoxus can be seen in severe emphysema. Can be seen in severe emphysema. It can be seen in 1/3 of the cases of constrictive pericarditis. So it can be seen in 1/3 of the cases of constrictive pericarditis as well. Okay. So how do we identify this Pulsus paradoxus? So this is identified using a sphygmomanometer. So this is identified using a sphygmomanometer. So normally you know that the Kortkopf sounds are heard during expiration. Okay, normally the Kortkopf sounds are heard during expiration. So what do you do if someone asks you how to demonstrate Pulsus paradoxus? You will have to raise the PP cuff and raise the pressure above the systolic blood pressure and start reducing it. So when you start hearing the Kortkopf sounds, normally it's heard during expiration. You keep on reducing the pressure to the point where the sounds are heard during inspiration and expiration. So we reduce it to the point where the sounds are heard during inspiration and expiration, and this difference, if it is more than 10 millimeters of mercury, if this difference is more than 10 millimeters of mercury, then this is what we call as the Pulsus paradoxus. Okay, so this is what we call as the Pulsus paradoxus. Fine. So I hope you've understood this entire concept of Pulsus paradoxus clearly. What is Pulsus paradoxus? What is the mechanism? And how do you identify it? Okay. Now let us move on to this next pulse form. What are you seeing here? You are seeing that the pulse has a rapid upstroke, rapid downstroke. So this is the rapid upstroke and rapid downstroke. This is what we call as the water hammer pulse or the collapsing pulse. So what is this instrument here? This is nothing but your water hammer. Right? So in those days there was a toy which was called as the water hammer. So this was filled with vacuum up to one half of the toy, and the other half of the toy was filled with water. And when you move it or shake it this way, you used to hear a sound which was like a hammer pounding. That is why this was called as a water hammer. So in those days when they discovered this water hammer pulse, this rapid upstroke and downstroke was having a resemblance to this toy, and that is why it was named as the water hammer pulse. So where do you see this water hammer pulse? It is seen in conditions where there is a high cardiac output. High cardiac output states. Where all do you see it? You can see it in physiological and pathological conditions. You can see it in anemia. You can see it in beriberi. You can see it in thyrotoxicosis. Right? You can see it in congenital heart diseases like ventricular septal defect and patent ductus arteriosus. So these are some of the conditions where you can see this Pulsus paradox. So these are some of the conditions where you can see this water hammer pulse. Okay. So how do you demonstrate for the water hammer pulse? How do you demonstrate for the water hammer pulse? You take the patient's hand and you hold it such that you compress the radial artery up to a point where the pulse is just felt. Once that is done, you raise the arm above the head. There will be an increase in the pulse volume followed by a sudden drop because of peripheral runoff, right? So this is what we call as the water hammer pulse. Another important valvular heart disease where the water hammer pulse is seen is your aortic regurgitation, where there is a wide pulse pressure. Okay. So this is about pulse for you. So we have learned everything about the pulse. We have learned the definition, the normal waveforms, the rate, rhythm, character, and the different types of pulse waveforms. Okay. So I hope you enjoyed this session. Thank you.